You're listening to the Primary Care PT podcast. I'm your host, Dr. Katie Obright, and we're going to talk all things primary care PT. Stay tuned and subscribe. All right. Hello, everybody. This is Katie Obright. I know it's been a while, a little bit of a hiatus since our last podcast has come out. Decided to take a little break for the summer, but in the fall, we will have all sorts of great episodes for you. And I'm really excited today to have a special guest, Dr. Ryan Jacobsen, who is a pediatric clinical physical therapy specialist. And he currently works for George Fox University out in Oregon. He's part of the same team that we had on the podcast previously. And I'm really excited to talk about how the primary care PT model can be integrated in a pediatric setting. And so I want to talk all things peds and early lifespan care with Dr. Ryan. Thank you so much for coming on the show today.
Yeah, thanks for having me. This is fun.
Yeah. So tell our listeners, and again, this is similar to our last episode with Kelsey Daniels. This is my first conversation ever with Ryan. So this is really an opportunity for all you listeners, people out there, to get to hear our first introduction to each other, which a lot of people have been saying is a really nice format. So tell me and all of our listeners a little bit about you, your background, and why this is important to you.
That's cool. I've been a pediatric therapist for about 23 years. I knew I wanted to go into pediatrics because I just like to play. My wife would tell you the same. And when I found physical therapy, it was amazing because it was like science and physics and creativity and everything involved. And what's really kept me there is the idea that you never just treat a child. Like there's a whole family and there's a social system and there's all factors that matter to that family have to be in play when you're with them. It's not your standard tennis elbow, right? It's kids with long-term developmental disabilities or kids with serious injuries or musculoskeletal complaints. But there's a parent, there's caregivers, there's family, there's real life out there. And I just love the mix. And I came to George Fox about 10 years ago, and that was fun because then I joined the faculty and started teaching pediatrics. And then I was around these amazing faculty clinicians who some have been on this show, and they just leveled me up. And what happened in that process was I just came along for the ride when we first started implementing primary care PT in the adult setting in Newberg, Oregon. And I just got involved with the research side and implementation. And so that has snowballed. And now we're kind of branching off into a world of what if this could happen in pediatrics.
That's awesome. And I'm eager to hear about how that is going and what you see the way forward, because I mentioned briefly just before we started recording that I wish, as a parent, my boys are 5 and 6. And I wish that my pediatrician's office had an integrated PT. They have integrated behavioral health. They also have an integrated dietitian. So, and I have found this, that a lot of the integrated team-based models kind of limit themselves just to those areas, behavioral health and or maybe dietitians and or maybe a clinical pharmacist. But so much of what is a risk factor for the way that somebody's going to develop throughout their life has to do with people's physical function, how they interact with their environment, their motor skills, their risk factors for obesity, those types of things. So I'm very eager to hear, first of all, how implementation in a pediatric setting has been going and what you see as the way forward for PTs that are interested in integrating in those settings.
Well, as far as implementation in a setting, as far as primary care, we're really in the exploratory phase. So I have a student research group at George Fox. We just completed a qualitative data collection from pediatricians across the region, getting their kind of input, which I can share with you a little bit later about what they see. But in the world at large, nobody has ever done this. I can't find it anywhere. The closest thing that's happening, and this would be like in Ireland, UK, Canada, Australia, is that pediatric physiotherapists are being uptrained in orthopedics And then they're the first access point in an orthopedic specialty, whereby instead of the surgeon seeing every appointment, many of those kids come in first and see the physiotherapist. And then it's actually the physiotherapist who decides, do you see the surgeon or not? We have advanced practice physiotherapists in Ireland who perform specialty procedures that the surgeon would usually perform, a Ponzetti procedure for club foot, or just general manipulative interventions or other things. And that child never actually needs to see the surgeon then. And it's brilliant because surgeons were, prior to this kind of service, operating on about 30% of the patients they saw for an initial evaluation. And now that number is up to 70% or 80%. So it's kind of an orthopedic specialty version of getting the right person to the right care at the right time, which is kind of what we talk about in primary care.
Exactly.
But in primary care, whereas all the pediatricians we've talked to so far in our research study are highly supportive, it's like you said, really, the current status quo is behavioral health, which has been embedded for a long time, nutrition, dietitian, and clinical pharmacy. And so this piece of it is something that really appeals to any pediatrician or NPPA, whoever, who's practicing in a medical home type setting.
Yeah. Okay. So that's interesting. So across the board, it seems like the pediatricians are pretty supportive of the care model and of the integration, but it's not happening. Why do you think that is? So they're supportive of integration, but it's not happening yet. And do they want it to happen? Are there plans in place to make it happen in the future?
I have not yet talked to a practice where there's active plans. The research study, which, kind of that classic qualitative semi-structured interview, really has become the introduction to the idea to many of these local and regional partners we talk to. Why it's not happening most recently is post-COVID and the realities of resources. One of the pediatricians, their practice is a private practice with 3 or 4 locations in the greater Portland area, said, if it was pre-COVID, they brought on dietitian understanding that it probably would not make money. And this pediatrician shared, in this day and age, post-COVID and the costs that came with managing COVID and stuff, the bottom line is a huge factor, whether you're a private practice, small, big, or whether you're a hospital-based practice. And so I think that the number one logistical obstacle to overcome is the cost to, the return on investment for cost.
Okay. So if it comes down to that, what are they basing their cost metrics on? Just space and salary? Are they considering reimbursement, alternative payment models? Because I do know that there's at least 2 models of practice where a private PT practice has integrated into a larger family medicine or private, primary care clinic, and they bill separately. So they have a PT rotating through, and they offer those services to their patients, whether it's, a quick screen, and then maybe they come and see them in their PT clinic, or they do evaluative services, but then those services get billed under the physical therapy clinics, numbers and everything like that. So has that been considered? What is the primary prohibitive factor from a cost perspective?
Yeah, I think that has been considered. And actually, if you talk to pediatricians and people in this space, like, they're the most creative, outside the box thinking people around. And it's wonderful to be around them. So we've had initial talks about alternative payment models, about embedded PT that also sees a private practice load as well, an integrative alternating model, the idea that if a pediatric PT became a part of that medical home service, it actually could increase physician PA and P revenue because they're freed up to actually get at more patients who, probably need them a lot. A group of pediatricians I spoke to said it would be so nice to have a pediatric PT embedded because I might spend 15, 20 minutes trying to sell PT, and then that patient goes off and I check in with them 3 months later and they never went to PT.
Hmm.
But if I could just have a quick handoff with a pediatric PT who could actually start intervention and gain that trust, I save time, the buy-in's there, and the therapy continues. Well, that's like a triple win. And I, as a pediatrician, can go on to other things where I'm needed. And I think we see this in adult practice too. Like, successful practices that both you, Katie, and I have been involved with, like everybody practicing at top of license with the people they need to be with, and knowing that other people who a PT needs to be with or behavioral health are taken care of is the ultimate of efficiency. I would say that my experience in hospital based, I've had a lot of experience both myself being in management and hospital based and with our partners, is that it's tough for a large organization to change their payment model and not see risk in that, not see risk in, well, this is how we calculate whether ends meet,
Hmm.
right? And so I'm sure you've experienced that too, where the idea of an alternative payment model really takes some form of initiative on the part of the organization up to the top of the organization.
Hmm. It
Um,
absolutely does. And I actually see a lot more barriers in larger health systems for that reason, because there's so many, signatures that you need to get on certain things. But my counter argument to something like that, or my first what's the word I'm looking for? Anyway, my counter argument would be there's significant risk in continuing to do things the way we're doing them too. Because the way that we're doing them right now is not improving population health whatsoever. In fact, it's just getting worse and worse and worse, and it's getting more and more and more costly. So I don't really understand that argument, but I really think it comes down to, and this is what I tell everybody when they're looking at implementing any type of new program where a PT is utilized in a non-traditional fashion, or at least non-traditional right now, but hopefully it'll be just more than traditional 10 years from now, is that they really need to strategically plan the whole entire implementation process. And it's all about building relationships and being able to have answers to any question that will come up along the way, to make it to demonstrate that this will be the right thing for patients, for the community, but also for the practice and for the organization. And in fact, I'm hosting a webinar next week, which by the time that this airs, it will be 3 months ago, and it'll be available online on demand. But the webinar that I'm hosting next week is actually about just that: how to improve practice sustainability by offering a primary physical health model of care. So I definitely think that this can be just a slam dunk and a game changer in the pediatric space. But it's going to take people like you, Ryan, who are just keep willing to continue to press and drive forward and, show how this will be effective. So what's next for you? Where do you see this going? Or, are
yeah,
you going to be like, won't take no for an answer, which I hope is the case?
absolutely. It's funny, you've obviously had this experience too, Katie. You get to a point in your career where you're like, hey, I love the work I do, but something's just lit me up. Like, I want to be a part of what the future of better healthcare can look like. I mean, we've loved our patients, their families, for years, and given them our all in the current system. And yet I've been luckily placed in this opportunity to say, hey, now that primary care is just starting to get a foothold in the adult world in the United States, let's start pushing forward in pediatrics. It's 100% a long game. Honestly, this first kind of like research study, which we hope to get published once we have all our analysis done, is really the first look into what even pediatricians' perceptions are for what this could be. I mean, we are really at the kind of like, that sounds like it could be a pretty good stage. But likewise, some of the pediatricians we talk to are also the medical directors of their clinic or of their space. And there's certain pediatric considerations that come up that I hadn't seen in adult. And I thought I'd share a couple of those.
Yeah.
One is the patient burden of cost. In Washington and Oregon, 60 to 70% of kids who are getting developmental ongoing therapy, so kids with long-term disabilities, are also on food stamps or some kind of public support. Like the
Wow, that's
socioeconomic
huge.
status is low, right? And to have an extra line item for even those patients who maybe have private insurance, but a line item of another therapist billing, coming into the office could be a deal breaker for them. And pediatricians are so good at being stewards of the cost for families who, are in a place where they're going to get ongoing care for the lifespan of the child.
Hmm.
Um, Even state insurance, then you're not going to make money off state insured kids, right? If you're going to do a traditional payment billing model. And
Hmm.
so with those kind of considerations, it really does, at least preliminarily, lean me towards the idea of how are we a physician extender? How are we someone who adds value to the total production of the clinic?
Hmm.
And maybe we're not the build component, because no pediatrician I've talked to wants to put extra financial burden on families.
Yeah.
So, yeah, I mean, I kind of diverged from the main question, but I felt like it was really telling meeting these medical directors and have them, bring up some real considerations that we hadn't really worried about in adult primary care.
So I have an interesting perspective on that. And
Mm.
this is something that I've seen and that I see as being the cost saver in the long run by integrating PTs in primary care. Right now, if you're I mean, so I'm in the Chicago metro, I think pretty much everybody knows that. If you get referred for physical therapy, most of what your options are going to be corporate practices. Corporate practices are high volume clinics because they don't have to be, but that's their model of care. They're seeing anywhere between 2 and 4 patients an hour. And the model of care is also, rewards PTs for higher productivity and for more visits per patient. So for example, and I'm not just spitballing this. I know this because I worked in it, I lived it, and I see it. And I see, new grad DPT students interviewing with places that this is what is offered to them. And so what you're going to get is you get a referral for physical therapy, you go to wherever, and they say, hey, we really want you to come in 3 times a week for 16 weeks for an ankle sprain, mild ankle sprain, or for, just your average acute low back pain. That's crazy. That's insane. And that is totally not what, first of all, it's cookie cutter. So it's not individualized care. It's based on, maximizing the number of visits that you can squeeze out of every patient that comes through the door, instead of expanding your model of care to being more, you have more cash services that are, offer preventive services or exercise-based services. But anyways, I digress. The options are limited when it comes to you're a patient getting a script for therapy, and then you go someplace and there is a fine line between what is medically necessary and what is not, and you can justify things any which way you want. So PTs in primary care, when we talk about that value proposition, the primary care PT, whether you're in a pediatric setting, whether you're in maybe a geriatric setting, or just general family medicine, that primary care PT, one of their primary roles is really to ensure, okay, what is most effective, what is going to be most effective for this patient, and how long is it going to take? Do they have very significant high needs right now? And what makes sense for them to taper off in the long run? Or is this something that can reasonably be managed once a week for a few weeks, and then every other week, and then maybe quarterly? So I just think that if we flip that and demonstrate that we can actually achieve the same outcomes with just better education, less visits, but more, long duration relationship building and relationship sustaining with patients over a long period of time. So
100%.
thoughts on that?
100%. It's I want to make a plug to anyone who's in pediatric therapy out there, OTs, PTs, speech therapists, that we, with our kids we're going to see long term, the model you just described, Katie, is exactly what we need. There are very few kids who need ongoing therapy forever. or even for months and months. Now, there are, and we have good evidence for certain times in life, early development, certain conditions, autism. There's some things where, yeah, you need that intensity, but by and large, this idea of managing care over a long duration is like, it's the win for therapy. And so why not start that earlier,
Mm-hmm.
not at the downstream referral to outpatient therapy? And
Mm-hmm.
I mean, we have good evidence that this works in chronic non-specific low back pain. The group out of Australia has published multiple papers on managing patients over 6 months with 7 visits, right? And showing 1 year outcomes for great
Yeah.
recovery that matches or exceeds what happens in traditional therapy models.
Mm-hmm.
But the plug I want to make to the pediatric therapists out there is, in my practice, because I also practice at Providence here in Oregon, and that's where I was before I even came to George Fox. You can practice in this mindset even in the outpatient space. And
Mm-hmm.
I would say that, if you're a pediatric therapist, you are at least working with OTs and speech therapists, maybe social work. And in my case, I have developmental pediatricians, psychologists, nutritionists, audiologists, and when I take on a caseload at Providence, when they call me in, that's how I manage care. I think, in the course of a fall of seeing kids, I might see 3 kids total ongoing weekly therapy. But the fact that I'm in this integrative kind of medical home downstream is exactly the model we're trying to move upstream into pediatrics. And you as a therapist out there right now, as in pediatrics, can practice like that. And like you say, no need for cookie cutter prescriptions. Have a dynamic plan of care. Start with the intensity you need and reevaluate in 3 weeks. We're all good. Here's another great thing about peds therapists and pediatricians and the like, is we're all good at honoring the fact that family life is just crazy. And this form of management actually gets better investment from our families and our kiddos in their communities than the idea of, wow, I have to go to speech therapy every week and OT every other week, and PT comes to my house once a week, and we have the pediatricians check-ins and stuff. This is why I'm fired up about primary care, because we could be in primary care, PTs, OTs, SLPs, and we could be delivering like point of contact, upstream initial things that, like you said, will significantly decrease the amount of total care they'll need for their condition.
100% agree with you. So here's an example. So I think most people know this as well. I started my career in the Army, and then most of the patients I've seen over time have been somewhere between the ages of 17 and 100. So I didn't have much experience in under 18 cases up until recently. And I started seeing a couple of kids, and one of them was a little awesome 9-year-old kid with a birth-related brachial plexus injury. And he was in therapy basically most of his early childhood, from, in and out of therapy from like ages 0 to 4. But it was this sort of episodic care model where it was like, okay, we'll do this certain amount of stuff for 12 weeks and then, discharge. And then it probably didn't make a whole lot of sense. Whereas if you saw this child and you identified these problems, you can sort of project what those types of problems might evolve into as that child grows and as their motor skills develop and all of this. So I saw him for the first time, and in discussing with him and with his parents, he has very similar positioning in his limb, in his upper limb, compared to what he had when he was 4. But when I like put on my, projection, future looking glass, I can see what that may develop into as he ages and as he, develops and does all these things. So my education right now is really forward thinking. So we're going to do less visits now, because I know I'm not going to totally change your posture that you've had your entire life. However, we can do certain things to optimize what you have right now to make sure that it is going to serve you best and reduce your risk the most over the long period of time. But I'm doing that early on. It was like once a week for 4 weeks. Now I'm really I want his mom to send me pictures of how he's looking in certain movement patterns every 3 weeks. And then I want to follow up with him quarterly and just make sure that he stays on a good path, especially as he goes through his pubescent years. and all of that. So it's this sort of long-term projection model for this child, and it's working outside of that traditional episodic framework. So thoughts on that?
Yeah, I think you've spoken about this before. I think the episode of care model is this weird thing that we've done in therapy that doesn't happen in the rest of, medical management or health and wellness in general.
I don't get
It's
it.
at Providence, I write plans of care for 1 year, and they have a certain number of visits. Sometimes they include like at the parent's discretion, because I want that kind of like ongoing relationship. And when I see kids at George Fox, because our pediatrics clinic is pro bono, it's just what you're describing. It's not episodes of care. It's where do we need to be right now? I'm always here for you, but go live life, right?
Mm-hmm.
And I think that's what our providers in pediatricians' offices do. I love some of the quotes. I wrote a couple of these down for today. One of the questions in our semi-structured interview research study is, what are the key aspects and attributes of a successful pediatric provider? And the things that came up is patience, playing the long game, not solving it all, and collaborating. You can never do this solo. I mean, we already know how to best care and promote health and wellness for children and families. And so, again, the plug out there is, do that in your outpatient pediatric practice. Break the mold a little bit and test the water with families who are willing to do that, and just see what comes out of it. It's super rewarding. And getting back to your original question, like, what's next for me? Next for me is getting this paper out there and finding one of these partners for a grant, to fund a grant to do a 1-year pilot of this in primary care. I think that's where we're going to learn a lot.
I think that is a wonderful starting point. And I think that will, the hope would be that would serve as a framework for others who want to consider doing the same thing and implementing the same thing. And again, when we look at these comprehensive primary care models, team-based primary care models, where there's usually, a physician and a nursing team, behavioral health, PT, OT, or other types of like rehab, functional neuromusculoskeletal type care services, clinical pharmacy. When we look at those teams, we know in the research that primary care expenses actually increase, but total healthcare expenditures, especially for specialty services, decrease. And that makes perfect sense. They decrease, and total healthcare expenditure is significantly less. So when you take these pools of money and you look at things in the grand scheme of things, you will probably see that. And I think that's our way that we can sort of justify our role and our place in primary care to insurance companies. And so are you aware of the primary care petition, the clinical specialty that's underway right now?
Yeah, I completed the survey and everything. I'm gung-ho for this.
Okay, awesome. So what are your thoughts on that? Because I know that there are some people who really think that the concept of the advanced generalist it just dilutes what we do and yada yada. I actually think the opposite. And it would help me understand your perspective as a pediatric specialist working mostly with pediatric cases, how you think the primary care specialization could potentially serve the greater all populations better. And like, if somebody was deciding, like, let's say primary care specialist was an option today, and a new grad PT was trying to decide between the two, like wanted to work with pediatric cases but wanted to be expansive, like what would be your guidance there? What are your thoughts?
I'm 100% supportive. Doing a board specialty in the United States is a way of leveling up your practice, whether you're a new grad or down the road. And in answer to the either or, it's not an either or. I think we've said this before, that in physical therapy practice, adult children, the ones who specialize and go deep are just as important as the broad generalist and the advanced generalist. And actually, we already have a model for this, and how over the past 10 years, advanced practice physiotherapy in the UK and in Australia has been formalized more and more. It's a pathway towards something that can contribute really high value needs to a health system that wants to be about population health. And
Mm-hmm.
that is not to the discrediting of those of us as therapists who also love going deep. And maybe I'm a specialist in neurology and pediatrics. Those therapists are needed and highly valuable too. And the either or for me is just kind of, I don't know, I hate either ors. I think there's a possibility for ands everywhere.
Yeah.
I would encourage anyone who's interested in kind of really leveling up how they manage in pediatrics the total care of their children that they serve and their families and caregivers. This is a formalized way of doing what you kind of already do. If
Mm-hmm.
you're out there right now and you're practicing in pediatric OT, PT, or speech, unless you're in a vacuum and you're the only one out there, you're already kind of a holistic generalist. Like, you're managing when medical things come up.
Right.
You're finding access to social work or resources in the community. Like, I have yet to meet a pediatric therapist who doesn't put their heart and soul into everything a family needs in order
Mm-hmm.
to make them successful for their kids. And so why not have a primary care specialty? I will sit for the exam as soon as it happens, for sure, and it'll be super fun because it'll be a lot of work to learn. So I'm excited.
That's awesome. So circling back, I have some questions about specific things that pediatric therapists do that maybe other therapists don't necessarily consider. And this is just as much for me as it is for anybody else listening out there. So in orthopedic practice, I'm an OCS, orthopedic clinical specialist, and in orthopedic practice, when you do when I did my residency and when I sat for the exam and everything, there's a little, maybe two questions on the exam about pediatric cases. Maybe there's a little bit more than that now. I don't know. It's a long time ago, but what are some things that you think that a general therapist who's not a pediatric specialist might need to know about working with children? So for example, if somebody is in a primary care setting and they're in a family medicine setting where they really can see all ages and stages, what are some really important things for PTs to be aware of as far as screening, understanding basic clinical presentations that come in, and risk factors?
Yeah. First, as a general rule, kids are not little adults. So
Good.
if you take the musculoskeletal diagnosis, there are things about the body that haven't developed. You have a growing system that includes growth plates, that includes much more active cell regeneration and resiliency. It's actually why so many kids, especially under 8, 9, 10, who have injuries, will never see a physical therapist. They won't need to. I mean, it's a rare case when a kid with a fracture or 3 weeks of knee pain, that it won't just work out. I mean, we talk about non-specific low back pain, and 90% of those will resolve, and 80 to 90% will resolve on their own just through normal course of the thing. It's even more so with kids. And so they're not little adults. Then that child, it's funny because my colleague Dan Kang, who you had on the podcast before, he'll come back from a day working in primary care and go, "Bro, saw a 14-year-old. I couldn't even get her to talk. Like, what do you do?" Like, so part of pediatric practice, especially, whether it's a musculoskeletal complaint or a developmental complaint, or you're seeing someone in primary care for metabolic type stuff, high BMI or other things, the first thing you have to do is somehow find the in with that kid. And it takes more time and more awkwardness than most adult therapists are willing to do. I have my own jam. I'm kind of goofy and I'm really loud and boisterous, and that works 90% of the time, and it crashes and burns 10% of the time. But if you're in practice, that's actually super important. To make the analogy, our therapists who are in adult practice down at Samaritan, I love shadowing and working alongside them, because they'll go in on a warm handoff and it'll be something like this. It'll be like, Yeah, so Katie, the doctor says that you've been having some knee pain. I know you've told it to them already. I just want to hear kind of like what's going on from your perspective, and the personal share, and then you it just is this instant like connection, like wow, this person's come in. Well, kids, they need that in a kid form.
Mm-hmm.
Um, there's very few kids who kind of like, hey, I'm really interested in why you're here at the doctor. Um, that doesn't connect, you know. What does connect is like, um, okay, so you know, what's this really getting in the way of for you? And I don't know. The kid will say, I don't know, and say, will you play sports or something? Oh yeah, I play sports. Oh man, you know, there's got to be some kind of in that you see that light up in the kid's eyes. It's funny too because your question would probably have made a lot of our listeners right now think, yeah, like what are the medical and orthopedic and neurological things I think should think of? But kids are the ultimate in the biopsychosocial model, emphasis on the psychosocial.
Mm-hmm.
Uh, Once you get that, then you can do screening, you know, just, you know, general systems review, screening questions. There, you don't have to worry about if there's special pediatric things you need to ask because the general thing that most therapists do for their initial screening is more than enough. Um, and when special things come up, just be willing to ask about it.
Yeah, that is really, really great. That's really great guidance. And honestly, when I hear you say that, it's interesting because that's exactly what we do with adults. You know, we always try to find common ground. We try to build that therapeutic alliance. But instead of maybe talking about, you know, how it's, you know, a patient can't get through their workday because it hurts to sit at their desk or it hurts to, you know, bend over and lift something heavy if they have a physical job, you're talking to a child who um, you know, maybe really likes to play soccer and or you know, they really like I don't know, like my boys love Sonic, you know, the new Sonic movie that came out. And so just thinking about what would light a fire for the kiddos that come to see you, what would
I
resonate with
I have to
them.
tell you this story. I had this kid at Providence last year, 14-year-old. She was slightly overweight, but she came in for tight heel cords, which surprisingly was happened a lot over COVID because kids were just sitting around not doing physical activity. So I saw a lot of
Wow.
post-COVID tight heel cords. But she's sitting there with her arms crossed and her eyes down, and you know, I'm talking a little with mom and I'm trying to get that in. And about 15 minutes in, I'm not getting anything from her. And so I just get up. We're in a therapy gym. I get up, and there happens to be one of those giant colorful bolsters standing up on end in the middle of the gym that I had been doing karate with the previous kid. And I just went over and I kicked it across the room right into the wall. And this girl's eyes looked up and I'm like, I got you. And then we spent the rest of the time karate kicking this thing and doing the assessment. It's just kids, you don't know what's going to get them. And the last thing I thought from this 14-year-old girl was that if I basically drop kicked a large bolster across the room and made a big crash, that all of a sudden I'd be cool. Right. And so I think it's fun just imagining how to access people and at their level wherever they're at. And you're right. That's the same thing we do with adults.
Yeah, absolutely. That's interesting. So I have another question. So coming back to one of our biggest roles in primary care is addressing population health and risk that comes along with that. And I know that the childhood obesity epidemic is it's not going anywhere. And I'm curious what your thoughts are on that, on, you know, how pediatric therapists you know, screen and intervene in that fashion.
I'll first make a plug for societal things. They're going to be the biggest change, how we set up our communities, how we value health and nutrition,
Mhm.
and how our culture views that. The second thing I'll plug for is if you're working in this space and you're seeing kids who are 11 or older, your intervention is really to focus on the child, not the family anymore, because that's a point of real independence. If it's younger children, it's kind of the family and the child.
Mhm.
Um, but in all those cases, uh, our our impact as physical therapists, if we take a traditional therapeutic exercise approach to high BMI and other metabolic things, is going to be pretty low success.
Yeah.
I think our biggest gift is understanding how motivating physical activity can integrate into the space and the routines of the family who's sitting right in front of you. And I think primary care is such a beautiful space for that. We talk about how awesome it is when you're a primary care PT that you're teed up for success by your provider when they do the warm handoff. Hey, Ryan, I've got my ACE PT, Katie, here. I want her to kind of take a look at this. She knows this stuff better than me. In pediatrics, that can be the same thing. When a pediatrician gets a kid and the discussion in their office has come up to like, hey, you know, we're in the 98th percentile for height versus weight versus height right now. Well, I want to bring in Ryan or whoever the pediatric therapist is, and he's my go-to guy. That tee up is such a nice thing versus a cold referral to PT for obesity and sedentary behaviors.
Absolutely.
So I think that's our biggest impact. Then we can approach both the physical activity side from a very what does your reality of your life look like? And I'm always here approach. And we can also start approaching basic nutritional concepts. We shouldn't shy away from well-grounded science in what we consume and how much we consume and where we get our food sourcing from. It doesn't have to be elaborate, but we can walk with our patients in that. And I think pediatric therapists are more and more doing that in the outpatient side. So that is where our one-to-one real impact's going to be. It's not going to be like, hey, the doctor called me in and it's time to give you 5 exercises and I'll print the med bridge or whatever pictures of it and I'm sure you'll go home and do it.
Yeah, so you made 2 amazing points. First being, in any integrated care setting, you're always going to have better success when you're in the same space and whoever is seeing the patient first speaks highly of you. We found this when I was at the cancer center. We found this all the time because we had like 3 oncologists that were, they loved what we did with our patients. They loved our model of practice, etc. And they would really tell these patients, we weren't in the same physical space. So they would tell their patients like, hey, this is really going to help you on your cancer journey. So at least go just one time just to get their opinion, get some education. You should go do this because I think this is what's best for you. Versus I rotated with some other oncologist physicians who would be like, you can go to PT. It might help. And then, that's such a difference when somebody who is hearing those 2 different things, one makes it sound great. The other makes it sound like, oh, well, I can just do this on my own kind of thing. So that's a huge, huge thing. And that's one thing that even up at Bellin Health, they have PTs in primary care where it's a non-revenue generating service, but they're actually seeing with these warm handoffs, they do these quick consultations and then they say, hey, why don't you come see us in the PT clinic for this many visits? I really think this is going to help you. And it's improving their referral to PT eval completion rate. So Absolutely. How many referrals do you get versus how many people actually come to their eval has gone up, which in turn improves the clinic sustainability. So that was the first thing you brought up, is that team integration, having of the provider that really makes it sound like seeing a physical therapist is worthwhile for whatever, given situation it is, really truly does make a difference. And then the second point that you brought up, which now I have to remember, you were just talking and now I'm losing it. What was the last thing you were just talking about, Ryan? Help me out here.
Oh, your memory is as good as mine.
Oh my goodness, look at us. We have the attention span of the children that we work with.
My wife and I joke that we should record conversations just to remember what we were talking about, and we're only in our 40s. So.
I know, I'm only 33. So, and I feel like this has kind of been me my entire life, but it could potentially be getting worse. But one thing that I am learning is whenever I know something or whenever if something comes into my head, I make a note of it. So what I should have done is I should have wrote down those 2 points that I wanted to talk about, but at least I got to the first one. Well, in summing up all of this, I do think that when we talk about primary care and we talk about physical therapists integrating into various primary care settings, there's a lot of different types of primary care. There's internal medicine, there's family medicine, there's geriatrics. There's lots of different stages of primary care. So you don't have to focus on just one of them. You can work in a pediatric setting and just have more of this primary care mindset. And regardless of whether you're integrated into a primary care clinic co-located, which sometimes is just not possible, or maybe it's not possible yet, but it could be in the future, you still can practice with this mindset of, think of the long term, think of that sustainable relationship with the patient, think of yourself as a member of that primary care team, as opposed to, oh, I'm just the therapist seeing the patient for, I don't know, a wrist sprain or whatever, tight heel cords. So Ryan, thank you so much. Do you have any parting thoughts? Anything that we didn't cover that you want people to know about, or how can people find you?
You can find me at George Fox University on the website. I'm open to anyone who wants to be a part of this or otherwise move this forward. It is literally getting in on the ground floor of something. My research team, I have 6 amazing doctoral students right now who spent a good 3 months trying to find if this is anywhere happening in pediatrics. And to this day, we still haven't found anything. So if you're out there and it's happening and you have a pediatric PT or OT or speech therapist already embedded in your pediatrician's office, please reach out to me. I would love to just knowledge share with you. But other than that, I'll double down on what you just said. We, as pediatric therapists, PT, OT, speech, anyone really, but the rehab specialties can really practice like this in our current settings. We already do to some degree. It's just about like stewarding more how we manage care over a longer time, by and large, getting away from kind of ongoing therapy when it might not actually be net positive. I'd say that I talked about Dan Kang, who's my colleague at George Fox, is one of the founders of all the work we've done in primary care. He looked at me one day and he said, you're going to laugh because he always starts with, bro. He said, bro, you pediatric therapists have been doing primary care and biopsychosocial for like 30 years. And he's kind of right, because you can't not do that. And so thinking about how the decisions you make in care with those families and those children, how that longer trajectory goes, and shifting when you can from a ongoing therapy mindset to a ongoing management of care mindset is super rewarding. It gets you access to more people because you're more open for new kids to come in who also might need your services. There's just a lot of cool benefits. And I'll say this too, if it doesn't fit you, I'll double down on what I said before, that there's space in this world for people who see themselves as needing to specialize deeper and deeper, and those serve those individuals really well. So I guess that's my parting shot.
Absolutely. That is wonderful. Ryan, this was an awesome discussion. I had a really good time getting to know you, and I can tell that, and I can just hear the passion in your voice behind expanding this space. So I hope that from this podcast, you'll get some, we'll kind of start to build a community for building out primary care PT in the pediatric setting. So I'm really excited for that. For those of you listening, if you're listening in probably August or September at this time, come join us for the Primary Care PT Summit in Waco, Texas, September 30th. We don't have any pediatric topics for that, but maybe we can jumpstart that in 2024, since we are going to make this an annual conference. And also, please, if you are not already, if you're an APTA member, join APTA Federal. It's only $25, and then you get to join our SIG, and you get all access to all of the resources. At APTA Federal is not just for federal people. I am not a federal person. So please consider joining us. That way you can stay connected and stay in tune with what's going on in primary care PT. So thanks so much, Ryan, and everyone have a good one. And that's a wrap. Thanks for listening. If you love our show, go ahead and subscribe to stay tuned for future episodes. As a thank you to our listeners, we're happy to offer $50 off of our Primary Care PT Foundations course or our Musculoskeletal Imaging certification. Visit us at redefinehealthed.com and use code PCPTPodcast, all one word, all lowercase, on the checkout page to claim your discount. That's PCPT Podcast, all one word, all lowercase. Until the next episode, stay awesome, y'all.